So I'd like to begin by thanking Professor Livio Prasutti for the very kind invitation to his Facial Nerve Symposium being held at the beautiful Bologna. I wish I was there, and I'm very grateful for the opportunity to speak at this lunchtime seminar. I'd also like to thank Ignacio, who's been coordinating with me online to get this talk over across to you. Now, I thought I'd fill in the program with a short discussion, just 15 minutes or so, on outcome measurement in facial nerve paralysis. It seemed to be an area that wasn't covered in the course, and I thought what I'd do is talk to you a little bit about the data for the last 20 years, looking at just a few slides on quality of life outcomes, but more importantly, trying to understand all of the publications on facial nerve outcome assessment, try and categorize it for you so you can have a conceptual framework of how to think of this. And broadly speaking, it's patient-related outcome measures that we'll talk about. It's subjective as well as objective assessment of facial nerve paralysis. We'll spend a few slides looking at how automation and AI is really likely to take over in the next 5 to 10 to 15 years our way of objectively assessing facial nerve outcomes. And then we'll talk about what the current state or the current suggestions are for your patients and how you should be monitoring them pre and post-operatively. Now, one thing that's very easy for us as clinicians is to empathize with our facial nerve palsy patients in the sense that we can really understand, or I should say sympathize with the fact that this is a significant deficit for a patient. We can really understand, particularly in the younger patient, how there are functional deficits that can occur around the orbicularis oculi and the orbicularis oris. But one important thing to remember is the impaired affective display that occurs, and that is sometimes patients that are wanting to display a positive emotion display a negative emotion. And I didn't really appreciate this until I read a lot of the literature for this talk, but it's really very easy to understand then why there can be an increased risk of depression in these patients, and why there can be an increased perception of negative emotion from the examined eye and from the layperson. So we can see in this work from Ishii and co-authors in 2012 that the facial nerve paralysis patient has a significant attractiveness penalty that they pay. You can see the shift in the curve to the left when patients are being observed by lay observers and in what they're trying to perceive. And you can see that there was an inability for the patient to express the joy that they had. And this is a really important part. And that is, and I'll highlight this, that there's an inadvertent increased expression of negative emotions. So imagine this. Imagine if you're excited and happy and you're smiling and you're trying to convey positive emotion to your friends and family, and it comes across the exact opposite as a negative emotion. This has profound impacts. And the largest patient-related outcome measures demonstrate that this effect seems to be greatest in our female patients and patients with long-term chronic facial nerve palsy. Now, when you're outcome tracking, a framework that I thought would be useful for you to understand is breaking it into this sort of way, and that is patient-reported outcome measures. And this is a type of classification that's becoming more and more important, not just in facial nerve surgery, but of course in all surgery, in all otology, neurotology, neurosurgery, facial plastic surgery. We'll look at clinical grading scoring systems, which we're all familiar with, House, BRACKMANN, SUNNYBROOK. We'll look at the current objective assessment tools as well, and how automation and AI will come to play a part in all of this. So your assessment should ideally be multimodal and incorporating all aspects of this. Now, interestingly, when members of the Sir Charles Bell Society were surveyed, patient-reported outcome measures were not being performed by the majority of clinicians. And I think as time goes on, our patients and also our colleagues and inadvertently our hospitals and the medical administrators will kind of demand this type of outcome measurement. There are two validated instruments that have been available for over 25 years for patient-related outcome measurement of facial nerve defects, and that is the Facial Disability Index, and the second is the Facial Kilometric Evaluation Scale. The Disability Index since 1996 has been a valid instrument with good inter and intra-observer reliability, looking at difficulty in smiling, difficulty in drinking and eating, but also social situations where the patient may not want to engage and not go into social scenarios. And this has been nuanced with the face scale, which is a more nuanced scale with a patient-graded instrument that allows us to assess the impact on various domains with appearance, physical appearance, experience, and psychosocial effects on the patient. In terms of subjective grading, there are generally a handful of grading systems that are being used. The oldest and most well-known is likely the BRACKMANN grading system from the mid-80s, and then the SUNNYBROOK from Toronto. The Facial Nerve Grading System 2.0 was really an attempt to try and modernize the BRACKMANN system, and then adding electronic electronic recording to this sort of a subjective grading system is the eFace system. Now, in terms of subjective clinical assessment, the SUNNYBROOK Toronto system is the most commonly used in the Sir Charles Bell Society Facial Nerve Study Group. It, as you likely know, is subdivided into 3 domains of static examination, dynamic examination, as well as synkinesis, and has good inter and intra-observer reliability, but it suffers from, like all subjective scales, the subjective nature, and so there is bias in this type of a scale. The oldest and the second most common system is the BRACKMANN system from the House Ear Institute, again with good intra and inter-observer reliability. Its big weakness is it doesn't have a lot of grading for synkinesis. It is subjective, and it was originally designed as a gross assessment tool. So for the modern clinician, they sometimes feel it's not nuanced enough to pick up the subtleties of some improvements that occur with certain patients. So it's certainly being decreased in its usage. The eFace system combines strengths of these previous 2 scales and plugs them into software for recording so that we can objectify at least the recording system here. It includes static and dynamic assessment as well as synkinesis, and its weakness as well is that it's subjected to human error, and it is subjective. So then a lot of facial nerve clinicians are moving to try and objectify their assessments, static and dynamic, including synkinesis and emotion, all trying to get all of these domains of facial nerve outcome assessment into an objective system. Here's an attempt from the Sir Charles Bell Society, published in JAMA Facial Plastic Surgery just about 5 years ago, looking at a standardized picture set from frontal view and from basal view, suggesting what clinicians should take a photo of pre and post treatment. But of course, this is static assessment. It's not dynamic assessment. This has been objectified and automated with this software called Emotrix, which places dots at various levels in the pupil, along the brow, in the corner of the mouth, and can measure various height differences and angle differences to, in a static assessment with 2 dimensions, at least try and automatize the system and record it reliably in software. So you can see here in a publication from 2018, demonstrating on the left-hand side pre-op and on the right-hand side post-operative treatment or recovery of the facial nerve, and how it can be quantified in this sort of software called Emotrix. There are other grading systems that look at not just what the clinician looks at, but more at what the layperson might look at. And this is important for the patient. Remember, as a patient-related outcome, attention of a layperson to your face is an important outcome. And we're using here visual tracking with heat map sensors to demonstrate in patients that have a normal face and then pre-treatment and post-treatment how the attention gaze of a layperson falls on the face. I love this YouTube video. This just really speaks to us as humans and how infectious smiling and laughing can be. And we actually don't really, I think, spend a lot of time properly thinking about this as clinicians, but you can imagine the impact of the inability to smile would have on a patient, not just on themselves, but on the people around them. And imagine if this patient of yours was wanting to smile, but when they smiled, they came across as having a negative emotion. You can see how this video really just sums it all up. That This spontaneous smile assessment is really the holy grail and the most desirable outcome of facial reanimation surgery. And that is the truly emotional smile. And it's very difficult to assess objectively. I mean, there are techniques objectively with tickle tests and things like that, but like all of these tests, it's subject to a lot of confirmation bias because we feel like we're doing good. So just something to think about with our objective assessment, that we're now moving into not just looking at subjective and objective assessment, but also emotional assessment and layperson assessment of the facial nerve. And this is where machine learning's coming in now. We all have AI chips on our phones. Our phones can scan through all of our pictures and identify people's faces quite easily and group them into friends and family. And we're all familiar with Big Brother and how cameras are all around us in our cities, and how facial recognition technology is being used throughout the world to unlock not just security for us, but also for helping companies track various techniques and ads and capitalizing on this sort of technology. And with this together, you can see how easily we can mix these two types of technologies with facial recognition and this objectifying of facial nerve paralysis to get a better understanding. So look at this. I got my MacBook and I was just loaded this software on. It's actually just run off the web, and it's a company called Afdex. And they allow you to have a sample of what their software is capable of. And this was using the AI chip on my MacBook and just the simple camera that I'm talking to you at now. And I watched this James Bond movie, and you can see the various domains that it's tracking: the valence, the expression, the brow furrowing, the brow raise, disgust, using the corner of my lips, the inner eyebrow raise. And every time there's a variation in color, it's demonstrating that just from the camera, using my own MacBook camera. So you can see in 2022, if we can do this, you can imagine what it's going to be like in 5 to 10 years' time, where we can easily combine these two to create an objective measurement. And here's some of the first publications doing this, where they're mixing the Afdex software and Emotrix, 9 normal patients, 39 patients with facial animation cases, demonstrating that the cross-facial innervated gracilis graft is superior to the mesenteric or dual innervated in these patients for spontaneous smile recovery. So this is very interesting early data, just demonstrating how we can get objectified, automated data in patients for recording outcome analysis. So in summary, it's really quite an exciting time for all of this. I think in summary, really, we should be still using the Sunnybrook grading system. That's still the most recommended by all the clinicians around the world because of the static, the dynamic, and the synkinesis domains, and the ability to have this graded and demonstrated across time. We should be using likely the more PROMs, more patient-related outcome measurements, and include these in our measurement outcomes. And likely AI analysis will create a whole new classification for us in analyzing our facial nerve patients. This has to be gratifying for us in terms of measuring our outcomes and comparing our outcomes and trying to improve our outcomes for these patients that really have a very tough time with their quality of life. So with that, again, Livia, I'd like to thank you for the opportunity to speak today, and looking forward to seeing you all live in Kyoto, just in under 3 months' time. So once again, thank you, Livio, and thank you, Ignacio, for helping me organize. And you guys take care and have a good rest of the conference.